Welcome to the Deep Dive. Today we're getting into Clostridium Difficile infection, CDI for short. It's something you'll definitely come across, particularly in healthcare settings, and it can be quite serious, especially for people who've recently taken antibiotics.
Exactly. And our mission today, really, is to give you a clear, high-yield rundown for revision. We sort of boiled down the key info you need on CDI.
We want to make this stick, so we're using some solid revision notes as our base today.
That's right, covering all of the essentials.
Okay, here's a quick thought to get us started. Your gut is packed with bacteria, like trillions of them, a whole ecosystem.
It really is.
But that balance is, well, pretty fragile sometimes. And antibiotics, while essential, can really throw it off balance.
That's the perfect lead-in, because that disruption is exactly what can open the door for CDI.
So we're going to unpack all of that, what CDI is, how it works, how you spot it, how you manage it, aiming for real clarity and hopefully making it easier to remember.
Sounds good. Let's dive in.
Okay, let's start right at the top, the definition. What exactly are we talking about with CDI?
Right, so Clostridium difficile infection, CDI, is basically a bacterial infection. It specifically targets the colon.
The colon, got it.
And it happens when this particular bacteria, Clostridium difficile or C. diff, you'll hear that a lot starts to multiply kind of out of control in the gut.
Right, so it's not just having the bacteria there, it's the overgrowth that's the problem.
Precisely. Normally, you've got loads of different bacteria keeping each other in check. But if something disrupts that balance, often antibiotics,
It's like you mentioned.
then C. diff can seize that opportunity and just flourish. And the illness itself, well, it can range quite a bit.
How so?
It can be anything from, fairly mild diarrhea to much more severe inflammation of the colon that's colitis. And in some cases, it can even be life-threatening.
Wow. Okay. So tell us a bit more about the bug itself, C. diff. What makes it tick?
Okay, so C. diff is a bacterium. It's gram-positive, rod-shaped. But the really crucial thing is that it produces toxins.
Toxins.
Exotoxins specifically. And these toxins directly damage the lining of the intestine, the colon. That damage causes inflammation.
And that leads to the symptoms.
Yes. And in some cases, it leads to something called pseudomembranous colitis that describes these sort of patches or pseudomembranes you can see on the inflamed colon lining.
Okay. And the antibiotic link?
Historically, clindamycin was a big one. Nowadays, though, we often see it linked with second and third generation cephalosporins. They seem to be common culprits for disrupting the gut flora enough to let C. diff take hold.
So the antibiotics clear the way and C. diff moves in with its toxins. Makes sense. Is there an easy way to remember that? A mnemonic, maybe?
How about the ABC of CDI? Antibiotics disrupt, bacteria cause the trouble via toxins, and colon is affected.
ABC of CDI. I like it. Simple, effective. Okay. Definition nailed down. Let's move on to the etiology, the direct cause.
Well, that's straightforward enough. The direct cause is the bacterium we've been talking about, Clostridium difficile.
And the mechanism, just to recap.
It's those toxins. The bacteria produce toxins A and B, mainly, and these damage the cells lining the colon. That leads to inflammation, fluid leakage, basically the symptoms like diarrhea.
And often triggered, as we keep saying, by antibiotics, especially in places like hospitals.
Exactly. Healthcare settings often see more cases because you have vulnerable patients, antibiotic use is common, and the spores of C. diff can survive in the environment and spread.
Right. Okay, so bacterium, toxins, often after antibiotics, often in hospital. That brings us neatly to who's most at risk. What are the key risk factors?
Top of the list, without a doubt, is recent use of broad-spectrum antibiotics. The broader the spectrum, the more disruption to the gut flora.
Makes sense. What else?
Older age is a big one. Patients tend to be more susceptible. Also, prolonged hospital stays more exposure risk, more likely to get antibiotics.
And sadly, if you've had it before.
Yes, unfortunately, a previous episode of CDI significantly increases your risk of getting it again. The gut environment might just be more vulnerable after an infection.
Okay. Any other major factors?
Definitely. Being immunocompromised, having a weakened immune system, having GI procedures or surgery can also disrupt things.
Right.
And interestingly, certain medications, particularly proton-pump inhibitors, PPIs.
Oh, PPIs. Why is that?
The thinking is that by reducing stomach acid, PPIs might allow more C. diff spores to survive the passage through the stomach and reach the colon. Normally, the acid kills off quite a lot.
Ah, okay. That's a useful detail. So a lot of factors point to either a weakened gut defense or increased exposure, got a mnemonic for these risk factors.
We could try AHPI, PPG. Let's see. Antibiotics, hospitalization, previous CDI, immunocompromised, procedures, GI ones, PPI use, and geriatric for older age.
HPIPPG. Okay, might take a bit of practice, but helpful. Quick scenario then. Young, healthy person takes a week of broad-spectrum antibiotics for, say, a sinus infection. Are they genuinely at risk?
Yes, they are technically at risk because of the antibiotic use. The antibiotics can disrupt their gut flora.
But less so than others.
Exactly. Their overall risk is generally much lower compared to an older person who's been in hospital and might have other health issues. It's all relative.
Good clarification. Okay, let's dig a bit deeper into how it causes disease. The pathophysiology, what's happening biologically.
So it really comes down to those toxins, again, mainly toxin A and toxin B. These toxins are the key virulence factors.
Virulence factors, meaning the things that make it harmful.
Precisely. They bind to specific receptors on the surface of the cells lining the colon.
And once they bind, what's the chain reaction?
That binding sets off a cascade inside the cells. It disrupts their structure, their function.
Yeah.
It leads to inflammation, cell death, and increased permeability of the gut lining.
Permeability meaning leaky.
Yeah, essentially. Fluid leaks out, inflammatory cells rush in. This causes the diarrhea, the pain, the mucosal injury, the actual damage to the gut surface, and, well, colitis, the inflammation of the colon itself.
So the toxins are absolutely central to the whole disease process.
Totally central. And remember, this whole damaging cascade usually only gets going because the normal protective gut bacteria have been suppressed, typically by antibiotics, allowing C. diff to multiply and produce enough of these toxins.
Right, that initial disruption is the prerequisite, isn't it? You mentioned a garden analogy earlier.
Ah, yes. Think of your gut microbiome like a healthy, diverse garden. Lots of different beneficial plants keeping things balanced. Antibiotics can be like a broad-spectrum weed killer. Maybe you were targeting one specific weed, but it harms lots of the good plants too.
Leaving empty patches.
Exactly. And that gives a tough, opportunistic weed like C. difficile the space it needs to grow rapidly and take over the garden.
That's a great visual. Really helps explain it.
Yeah.
Okay, so we understand how CDI happens, but if someone comes in with diarrhea and tummy pain, it's not always CDI, is it?
No, absolutely not.
So what else should be on the list? What are the differential diagnoses?
Good question. You need to consider several other things. Common culprits include viral gastroenteritis, your typical stomach bug.
Right, very common.
Then there's inflammatory bowel disease, IBD. So conditions like ulcerative colitis or Crohn's disease, they can cause similar symptoms.
Okay, IBD.
Irritable bowel syndrome, IBS, can cause abdominal pain and altered bowel habits, though usually more chronic. And, of course, other bacterial infections, things like Salmonella, Campylobacter, E. coli.
So quite a few possibilities. Any tips for remembering those differentials?
Maybe think in categories. You've got viral causes like gastroenteritis, inflammatory causes like IBD, functional disorders like IBS, and then other bacterial infections. Grouping them might help keep them organized in your head.
Viral, inflammatory, functional, other bacterial. Okay, that works. So quick check again. Patient presents with new onset diarrhea, abdominal pain. Besides CDI, you're thinking?
Definitely viral gastroenteritis, maybe IBD like UC or Crohn's, potentially IBS if the pattern fits, and other bugs like Salmonella or Campylobacter.
Perfect. Now, zooming out a bit, what's the picture like in the UK regarding CDI, the epidemiology?
Well, in the UK, CDI has been and still is a significant healthcare-associated infection, or HCAI. It causes a lot of problems in hospitals and care homes.
But I heard things might be improving.
Yes, that's the good news. There's been a definite downward trend in incidence over recent years. That's largely thanks to much better infection prevention and control measures in hospitals. Things like antibiotic stewardship, better cleaning, isolating patients.
That's really positive.
It is. But we can't get complacent. CDI still places a heavy burden on the NHS, especially affecting the elderly and immunocompromised patients. They tend to get sicker and have worse outcomes. So ongoing awareness and prevention are still absolutely key.
Right, continued vigilance needed. Okay, let's get practical. What signs and symptoms make you really suspect CDI in a patient? Clinical features.
The presentation can vary quite a bit, as we said.
Yeah.
But the hallmark symptom is usually diarrhea, often watery, sometimes frequent.
Diarrhea. What else?
Abdominal pain or cramping is common too. Fever, loss of appetite, maybe some nausea.
Standard sort of gastro symptoms then. What flags it up as potentially more serious?
Yeah, in more severe cases, the diarrhea can be really profuse, like multiple times an hour. Patients might have a high fever, their abdomen might become noticeably swollen or distended,
Distension, okay.
and they might show signs of systemic inflammation, like a rapid heart rate, low blood pressure. This indicates the infection is having effects beyond just the gut.
And the really scary complications.
Well, severe CDI can lead to toxic megacolon, where the colon becomes massively dilated and paralyzed, which is a surgical emergency. It can lead to sepsis, the body's overwhelming response to infection, and tragically, it can lead to death.
So it can escalate quickly. Are there any typical lab findings you'd look for?
Yes, a raised white blood cell count, the WCC, is very common. It's a general sign of infection or inflammation, but it's often quite significantly elevated in CDI.
Okay, raised WCC. And you mentioned a severity scale used here in the UK, Public Health England's scale.
That's right. It helps stratify patients and guide management. Mild CDI is usually defined by a normal WCC, maybe 3 to 5 loose stools a day, or R, perhaps just a temperature over 38.5 degrees C.
Okay, mild is fairly contained. What about moderate?
Moderate CDI often involves a raised WCC, but typically below 15 times 10 to the 9 per liter. Or another marker is an acute rise in creatinine. That's a kidney function test going up by more than 50% from their baseline.
So kidney function can be affected too. And then severe and life-threatening.
Severe CDI usually means the WCC is high, over 15, or there's clinical or radiological evidence of severe colitis. So, signs on examination or on scans suggesting significant bowel inflammation.
And life-threatening.
That's the really critical end. Features include things like hypotension, low blood pressure, signs of ileus where the bowel stops working, toxic megacolon itself, or CT scan findings showing very severe disease.
That scale seems really useful for classifying how sick someone is. Any quick memory aid for the core symptoms?
Maybe just think. Diarrhea, fever, abdominal pain. Those are the big three. And for severity, kind of layer it. WCC and stool frequency temp for mild, add creatinine for moderate, then look for those major signs of colitis or systemic upset for severe life-threatening.
Diarrhea, fever, abdominal pain. Got it. Okay, so you suspect CDI based on symptoms. How do you confirm it? What are the investigations?
The definitive investigations involve testing a stool sample. You need to look specifically for the Clostridium Difficile toxins or sometimes the genetic material of the bacteria itself.
Stool tests. What kind?
The main methods used are enzyme immunoassays, EIAs, which detect the toxins A and B, or increasingly common now are PCR assays.
PCR, like for COVID?
Exactly the same principle. PCR detects the bacterial DNA, specifically the genes that code for the toxins. It's very sensitive.
So EIA for toxin, PCR for the gene. Does it matter which one?
Well, PCR is more sensitive. It can pick up very small amounts. But detecting the toxin itself with EIA is arguably more specific for active disease, as it shows the toxin is actually being produced. Often labs use a combination approach.
Okay. What about scans or scopes?
In most mild or moderate cases, you don't need imaging. But in severe disease, or if you're worried about complications like toxic megacolon or perforation, then an abdominal X-ray, or more likely, a CT scan, can be very important. Endoscopy is usually reserved for complex cases or diagnostic uncertainty.
So imaging for severe cases or complications. And that stool test, a positive toxin test, is key for diagnosis.
Absolutely. Finding the Clostridium Difficile toxin, the CDT, in the stool is the cornerstone of diagnosis for active CDI.
What if you only test for the antigen, not the toxin?
That's a really important point. Some tests detect a C. diff antigen called GDH. A positive GDH just means the bacteria is present or you've been exposed. It doesn't necessarily mean you have an active toxin-producing infection. You really need evidence of the toxin for a firm diagnosis of CDI.
Right. Antigen means exposure. Toxin means infection. Good distinction. Okay. Diagnosis confirmed. What's the plan? How do we manage CDI?
Right. Management. Step 1. Absolutely crucial. Stop the offending antibiotic, if at all possible. The one that likely triggered the CDI.
Stop the trigger. Makes perfect sense. What next?
Then you need to start an antibiotic that specifically targets C. difficile. The main options used in the UK are oral vancomycin or oral fidaxomicin.
Oral, even though it's a gut infection.
Yes, that's key. You need the antibiotic to stay in the gut and reach high concentrations in the colon where the C. diff is.
Yeah.
IV vancomycin, for example, doesn't get into the gut well, so it's not used for standard CDI treatment.
Okay. Oral vancomycin or fidaxomicin? What about more severe cases?
If someone is severely unwell, they'll almost certainly need hospital admission. They'll need supportive care, IV fluids for dehydration, close monitoring of vital signs, electrolytes, kidney function.
Intensive support.
Yes, and for those really tough recurrent cases or ones that don't respond well.
Yeah, you mentioned recurrence is a
It
problem.
really is. For recurrent or refractory CDI, something called fecal microbiota transplantation, or FMT, is becoming a more established option.
FMT. Tell me more.
It involves taking stool from a healthy screen donor and transplanting it into the patient's gut, usually via colonoscopy or sometimes capsules. The idea is to reintroduce a healthy, diverse gut microbiome to outcompete the C. diff.
Wow. Replacing the whole garden, essentially.
Kinda, yeah. It can be remarkably effective for breaking the cycle of recurrent CDI. And finally, never forget infection control and hospital hand washing, isolation, cleaning. It's vital to stop the spread.
Absolutely. So can you give us a quick guide to which antibiotic when? First episode versus recurrence?
Sure. For a first episode, generally mild to moderate, the standard UK first-line treatment is oral vancomycin for 10 days.
Okay, vancomycin first.
Oral fidaxomicin is often considered second line or sometimes first line in specific situations, perhaps if recurrence risk is high. There are some guidelines suggesting maybe using vancomycin plus IV metronidazole as a third line, but vancomycin or fidaxomicin are the main players.
Got it. And if it comes back, recurrence.
This is where it gets a bit nuanced. If the recurrence happens quite soon, say within 12 weeks of finishing the first treatment, then oral fidaxomicin is often preferred. It might have a slightly lower risk of further recurrence compared to vancomycin.
Okay, fidaxomicin for early recurrence. What if it comes back later?
If it recurs after 12 weeks, then you can use either oral vancomycin again or oral fidaxomicin. The choice might depend on previous treatments and patient factors.
Right. And the really severe, life-threatening ones.
For life-threatening CDI, the recommendation is usually a combination. Oral vancomycin, often given via nasogastric tube if needed, PLUS intravenous metronidazole, or via metronidazole does get some gut penetration and adds extra cover.
Both oral vanc and IV metronidazole.
Yes. And in these critical cases, you absolutely need specialist input, infectious diseases, gastroenterology, maybe even surgeons, as surgery to remove the colon might be life-saving in dire situations.
Wow. Okay. You mentioned another drug earlier, Bez something.
Bezlotoxumab, yes. It's a monoclonal antibody, not an antibiotic. It targets toxin B specifically.
So it neutralizes the toxin.
Exactly. It's given as a one-off infusion alongside antibiotic treatment, and its main role is to help prevent recurrence, particularly in high-risk patients.
Does NICE recommend it?
Currently, NICE guidance suggests it's not cost-effective for routine use in preventing recurrence in most patients, but it might be considered in very specific high-risk scenarios.
Okay. And FMT, just to confirm, that's for multiple recurrences.
Generally, yes.
Yeah.
FMT is usually considered for patients who had 2 or more previous episodes of CDI, so they're really stuck in that cycle.
Right. Provides a clear picture of the treatment ladder. Okay. After treatment, what's the outlook? The prognosis?
As you'd expect, it really varies. Depends heavily on how severe the infection was to begin with and the patient's underlying health, age, other conditions.
Makes sense.
Mild cases caught early and treated appropriately usually have a very good prognosis. People recover fully. But severe CDI, especially with complications, can definitely be life-threatening, even with the best treatment.
And that shadow of recurrence hangs over people.
It does. Recurrence is the major long-term concern for many patients. Even after successful treatment, the risk is significant, maybe 20–25% after a first episode, and even higher after subsequent episodes. So, prompt diagnosis, the right treatment first time, and good infection control are all crucial for improving overall outcomes.
So, treatable for many, but potentially very serious, and recurrence is a real issue. Finally, let's just reiterate those potential complications.
We've mentioned them, but it's worth listing them clearly. Severe colitis is a major one that can progress to toxic megacolon, that dangerous dilation of the colon.
Okay.
Then there's the risk of bowel perforation, a hole forming in the colon wall, leading to peritonitis, sepsis, as we said, a systemic infection, and ultimately death.
Serious stuff.
Definitely. And even without those immediate life-threatening complications, recurrent CDI itself is a major complication, causing prolonged illness, reduced quality of life, and significant healthcare costs. It all stems back to that toxin-mediated damage and the resulting inflammation.
So what might start as diarrhea can spiral into really severe problems if things go wrong.
That's the key message, yes. Don't underestimate it.
Okay, well, that wraps up our deep dive into Clostridium difficile infection. A lot to take in, but hopefully useful. Let's quickly recap the absolute must-knows for revision.
Okay. CDI, bacterial infection of the colon. Caused by C. diff overgrowth, usually after antibiotics disrupt the normal gut flora. Key risks: antibiotics, age, hospitalization, previous CDI.
Symptoms: think diarrhea, fever, abdominal pain. Diagnosis: crucial stool test for C. diff toxin, CDT. Management: stop the trigger antibiotic if possible. First-line treatment for a first episode is usually oral vancomycin. Remember, recurrence is common.
And don't forget those mnemonics: ABC for definition, AHPIPPG for risks, and remember the severity scale helps guide treatment.
Perfect. So here's something to mull over as we finish. We've talked a lot about antibiotics triggering CDI. How much impact could really robust antibiotic stewardship using antibiotics more wisely have on preventing CDI in the first place?
That's a huge area. Reducing unnecessary antibiotic use is probably the single most effective prevention strategy we have.
And looking ahead, what about things like FMT becoming more mainstream or developing even more targeted therapies? Could that change how we handle difficult or recurrent cases in the future?
Absolutely. Research into the microbiome, refining FMT, developing new non-antibiotic approaches like bezilotoximab or others. It's a very active area. The hope is to get better at both treating acute episodes and preventing those debilitating recurrences. Lots to think about.
Definitely food for thought. Well, thank you for guiding us in all that detail.
My pleasure. And thank you, our listener, for sticking with us through this detailed look at CDI. We really hope it's been helpful for your revision and understanding.
Yes, absolutely. And if you are revising for exams, particularly the MSRA, do check out passthemsra.com. And there's also freemsra.com for, well, free resources. Both are great tools.
Definitely worth a look.
Thanks again for tuning into this deep dive. We'll catch you on the next one.